So that is setting the stage actually for our next speaker. And we welcome Professor James Chodosh. Already you've heard the introduction, but for those who joined in late, Dr. Chodosh is probably one of the most well-known names in ophthalmology at this point in time, especially during COVID era. And we'll go on to his talk. He's going to talk about HSC for us.
Thank you. Can you see my screen?
Yes, we can.
Great. So thank you. It's a really pleasure to be with all of you. I wish I was with all of you in person instead of on Zoom, but this is the world we live in for the near future. So I was asked to talk about herpes simplex virus keratitis. Excuse me. I have no interests, financial or otherwise, relevant to this presentation. This is a case that I thought I'd start with. It's a 20-year-old woman who came in complaining of a red eye and a sore throat. And this is the back of her throat, pictures that we took in clinic. And you can see on the right side of her throat, these vesiculopustular lesions. This is an image of her ocular surface. And I think your attention will be drawn immediately to the coarse dendritiform lesions in her corneal epithelium, maybe a suggestion of terminal bulbs in a few of these, but I would also bring your attention to these eyelid margin ulcerations. Herpes simplex virus type 1, or human herpes virus 1, is an enveloped double-stranded DNA virus, and it's said to be the leading cause of infectious corneal blindness. At least that's what all the grant applications say that are applying for research funding on this disease. There are numerous ways to make the diagnosis, but practically speaking, they're only useful for epithelial keratitis, and for almost all of those cases, the diagnosis can be made clinically. I would note that a common error still, at least in the US, is to send for serology, and unless the patient is very young, serology is rarely helpful because infection is so ubiquitous. Herpes simplex virus type 1 can cause infection of almost any eye tissue. I've never seen a lenticular infection, but anywhere else you can think of in the eye can be infected by HSV1. And this is the images of that young woman. Again, for our own interest, we both cultured her and sent for serology. She was 20 years old, and the culture was positive for HSV1 from the eyelid margin. And the serology showed a positive immunoglobulin M. And this was a primary infection, which we later came to believe was sexually acquired in this young woman. So I want to focus a bit on the classification of this disease, because I think we've identified over the years a lot of confusion about HSV keratitis. And I believe that confusion comes about principally because there's so many manifestations, and these varied manifestations have very different names, and those names vary by region in the world, such that it's even difficult in some cases to interpret the literature with regard to the disease. And we've advocated very strongly for an anatomical classification system that any eye care provider who knows how to turn on a slit lamp should be able to do. And that would divide the disease into epithelial keratitis, stromal keratitis without ulceration, meaning epithelium intact, epithelium not intact, and endothelial keratitis. Epithelial keratitis sometimes is punctate, linear, but most commonly dendritic or geographic. Stromal keratitis without ulceration has been called interstitial keratitis, non-necrotizing, or immune stromal. I've always objected to the last term because it implies that other forms of herpes keratitis don't involve the immune system, and that's not correct. Stromal keratitis with ulceration, also known as necrotizing. Necrotizing inflammation is something that pathologists can call, but as clinicians, when we use the term, we like to use that term, but it's not really appropriate. And finally, endothelial keratitis, which at least in the US and I believe in India is often referred to as disciform keratitis. But interestingly, in Japan, the use of the word disciform is with stromal keratitis without ulceration. So there's one example of where the terminology, because it's anachronistic, is confusing. So really what this requires is that you look at the cornea with the slit lamp and determine where the greatest degree of involvement is. This has been codified in the Academy sponsored clinical guideline that we published some years ago, which I'll mention again. This classification system is not novel. In fact, Leopold and Siri proposed an anatomical system like this back in 1963, and I'm sure if we looked hard, we could find prior examples of this sort of anatomical approach. So what you really need to do to classify it is to pay special attention to the layers of the cornea and also the anterior chamber. And the goal of this is to be able to go from a simple classification to a treatment algorithm. Without that, the treatment algorithms are very confusing. So in this scenario, if you're cloud gazing and you see one that looks different, and in fact, it looks like a falling airplane engine, maybe it is. Maybe you should get out of the way in that case. This is epithelial keratitis. And you see here the geographic components in the upper part of your slide, beautiful terminal bulbs at the lower part of your slide. And very commonly, there's a mixed picture. Geographic epithelial keratitis where the basement membrane has been laid bare, and dendritic keratitis, not so much. This is a slide from Kirk Wilhelmus showing HSV lytic antigens in the corneal epithelium, and epithelial keratitis is literally an infection of the corneal epithelium. Here it is stained with lissamine green, which beautifully stains both the edges and the stromal base. Fluorescein, which stains better the base. Rose bengal, which stains only the edges. And by this point, you can see the patient is getting dry from all our staining. This is not epithelial keratitis. This has been called a ghost or footprint. It's what you see at the last stages as the epithelial keratitis is resolving or is just resolved. It's a subepithelial haze that takes on the shape of the dendrite. And this does not require treatment. These typically resolve on their own. And I'll show you in a moment a case where I, in my younger years, treated one and created a problem for the patient. This is stromal keratitis without ulceration. These literally look like nebulae or clouds in the corneal stroma, and they can occur at any level of the cornea. You can see superiorly deep, full thickness, and superficial involvement. Here's another case, and they're very commonly multifocal, and they literally do look like clouds floating around in the cornea. They can be denser though when they're more active. And here I think you can see very nicely how well demarcated they can be by level. They can be only in the posterior cornea with a very sharp demarcation line, almost like the person has had LASIK. They can be mid-stromal, anterior. There's really no rules about depth location. And it's very common to see them at various depths and various locations. This, on the other hand, is stromal keratitis with ulceration. And I haven't stained this, but if you can see my pointer, the outline of the epithelial defect is here. They're very strong inducers of neovascularization. They very commonly occur or start in the periphery and can confuse you in that they are a form of peripheral ulcerative keratitis when they present in the periphery. They characteristically march toward the center of the cornea when treatment has not been appropriate. They leave behind a thinned, deep, densely vascularized cornea, and they will cross right into the visual axis while you're watching them or perhaps treating them as if they're microbial, not considering a herpetic source. So these are the ones that are most commonly misdiagnosed. This was the patient I mentioned who had an epithelial dendrite, had a ghost subepithelial stromal opacity as they were resolving. I thought, maybe I should treat that with steroids. They developed this geographic epithelial keratitis that you can see outlined with rose bengal. I quickly withdrew the steroids and induced a rip-roaring stromal keratitis with neovascularization. All of it preventable. Had I just cooled my heels and relaxed, it would have just all resolved. So don't make that mistake. This is endothelial keratitis. And in this situation, the stroma has very few white cells. The inflammation is targeted at the corneal endothelium. And I think you can see these large keratic precipitates with overlying very well demarcated stromal edema with epithelial microboli and microcystic edema. Here's another case. This is HSV endothelial keratitis. And you can see what looks like a Coudeuse line, but this patient has never had a corneal transplant. The problem with calling this disciform keratitis is that sometimes it's diffuse. And when it involves the whole cornea, it's the same process, but it's not disciform. That's difficult to make the diagnosis because you can't see the anterior chamber in that case. Your only clue sometimes is an elevated intraocular pressure, which would be characteristic of a herpetic infection. The reason I asked you to look not only at the layers of the cornea, but also the anterior chamber in all cases, is because you might confuse this with a keratouveitis. In keratouveitis, the inflammation is targeted at the uvea, and you get spillover with a bathtub ring of precipitates on the cornea. But the anterior chamber response is the major site of inflammation, so you will have 2 to 3 plus cell in the anterior chamber and some keratic precipitates. In HSV endothelial keratitis, there's a paucity of anterior chamber cell. You may see no cells or trace cells, but yet you see these very impressive keratic precipitates. And that's how you make the diagnosis of endothelial keratitis as compared to a keratouveitis with endothelial keratic precipitates. Okay, there are some special considerations in HSV keratitis. There's atopy. It's said that HSV is more common in atopes, more likely bilateral and more likely recurrent and harder to treat. And all of these are based on case series, but I believe them based on my personal experience. If you look at the literature, it says that 5% of HSV keratitis is bilateral. In my experience, almost all of the bilateral cases have had the triad of atopy. This was a case in point, a patient with bilateral lid margin ulcerations and a coarse epithelial keratitis. This patient was asthmatic, and he presented with his first case of epithelial keratoconjunctivitis and blepharitis. What about following penetrating keratoplasty? It's almost always epithelial, not always, but usually. And that's because these patients are typically on postoperative corticosteroids, which, as we know, can enhance or enable epithelial infection by the virus. And it should always be an indication for oral prophylaxis. Personally, I tell patients planning to have surgery with a history of HSV keratitis that they will be on oral antiviral prophylaxis for life. And that's because we don't really have any clinical data suggesting when it's safe to stop. This is a patient. Elmer will recognize this slide. It's from the Bascom-Palmer slide set. It's a patient with a corneal transplant on corticosteroids who developed a largely geographic but partly dendritic HSV epithelial keratitis, stained here with rose bengal. What about quiescent disease? You can have non-healing epithelial defects. We would characterize them typically as neurotrophic keratitis. They used to be called metaherpetic, stromal scars, vessels, lipid keratopathy. And if you don't treat endothelial keratitis promptly and properly, you can have permanent damage to the corneal endothelium and have persistent corneal edema that lasts for the lifetime of the patient unless treated. This is a 13-year-old who never received proper treatment, came to me with a quite poor vision with extensive lipid keratopathy. I believed at the time this was all avoidable. This is a patient that was sent to me by a corneal specialist who had never received oral acyclovir, had a graft for HSV keratitis, and had repeated episodes of stromal keratitis with ulceration that were here marching toward the center. And I'll return to this case toward the end of my talk. We set out quite a few years ago to look to see what was the evidence-based foundation for the treatment of HSV. And I'll not bore you with all of this, but what we found was a lesson in clinical trial history in that only the herpetic eye disease study trials, which I'll mention again, used proper methodology in which they calculated sample sizes a priori or prior to starting the trial and were properly powered. So only the head studies could really be looked at as level 1 evidence. I know you can't read this. These were the epithelial keratitis trials that we found at the time. These were trivial to me, and I was shocked to see how many there were, because no therapy for HSV keratitis really does much more than shorten the course by a couple of days. And epithelial keratitis, unless the person's immune suppressed or on corticosteroids topically, will resolve without treatment. On the other hand, the stromal keratitis studies were more interesting. Back in 1983 and then in 1992, there were 2 studies of betamethasone showing that it was better than placebo when given topically in the setting of topical acyclovir, and then the famous herpetic eye disease study, first authored by Wilhelmus, that showed that prednisolone, given in the context of topical trifluridine, which was the topical agent available in the US at the time, was better than placebo and trifluridine in treating stromal keratitis over a 10-week course. Importantly, and I think the most important findings from all of the head study was the acyclovir prevention trial, which showed that 400 milligrams twice a day of oral acyclovir reduced the rate of recurrent HSV stromal keratitis by about half. So not to zero, by about half, and that will come up in a moment. So these were prospective clinical trials, multi-arm, double-masked, multi-center, funded by our NIH. And you could summarize them as saying, for stromal keratitis, corticosteroids treat and acyclovir prevents. The studies also showed that adding acyclovir to a topical agent, adding oral acyclovir to a topical agent when already treating with corticosteroid was of no additional benefit. So multiple antivirals don't really help you, and that you can't use antivirals to prevent recurrence. In a patient with epithelial keratitis, adding an oral antiviral doesn't prevent recurrent keratitis later. But if you study clinical trials, you'll see that in order to get to an interpretable outcome, you need to have a clear question. And clinical trials, when they have a finding, often lead to new questions which were not answered by the trial. So we learned that topical steroids with a prophylactic antiviral work for stromal keratitis, and that oral acyclovir is no additional benefit when treating topically with an antiviral and a corticosteroid. But the question remains, would there be an advantage to use of an oral agent instead of a topical agent for stromal keratitis when treating with corticosteroid? We know that long-term acyclovir reduces the rate, but we don't know who should receive it, and we don't know how long, as was mentioned. We also don't know whether an increased dose or a different oral antiviral agent would be more effective in prophylaxis. No one has ever studied these in a randomized clinical trial. And another question comes up is, would an infrequent low-dose topical corticosteroid further prophylax patients against recurrence? There's some evidence from surveys that we performed that corneal specialists like to add an infrequent or low-potency corticosteroid to their prophylaxis. But again, that has never been studied. One of my interests has been how to diffuse information, for example, from the herpetic eye disease study into clinical practice. All of you on the panel, at least, are corneal specialists, and all of you know that you see patients who come from outside who are referred in which the treatment that you would rather provide may not have been given. So how do we deal with that? It turns out that if you study across the board, there's a 17-year lag between the introduction of new information and its full implementation into clinical practice. How do we speed that up? Well, courses like this, but this has limited reach. In the US, we have recertification exams, but you could get every question on HSV keratitis wrong and get all the macular degeneration questions right and pass this test. We have in the US scope of practice restrictions telling what specific eye care providers can and cannot do, but these are regressive and haven't been shown to actually improve care. In some cases, they restrict bad care, but they don't seem to be improving care. We also have financial means through Medicare started to reward us for evidence-based care, but they quickly became penalty-driven. So now we're penalized if we can't show that we have followed evidence-based care. And I object to regressive measures personally. We wrote and published this clinical practice guideline, which very few people look at because it's time to do that. I personally believe that the future is bright because as we develop electronic medical records that are actually intelligent and actually learning tools, we can, as you enter clinical findings, for example, the electronic medical record could lead you to a differential diagnosis. And once at that differential diagnosis, the electronic medical records could suggest treatment algorithms that are evidence-based. So the trainee in the future, if they're able to do the examination, and obviously we would still need to do an examination, or perhaps we'll have digital photography reading those exams and telling us what to do, and maybe the patient can get their treatment from home. But in the near future, electronic medical records have huge potential to improve evidence-based implementation. And then we're learning a lot in the US from the IRIS Clinical Disease Registry. Over 70% of US ophthalmologists are now contributing data. There are huge numbers of patients whose data is in this registry. And we can learn a lot outside clinical trials with this data. So I'm cautiously optimistic that this 17-year odyssey from new information to implementation will improve. Okay, now to therapy. I like to mention to you that a lot of what I say is evidence-based, meaning it's me sitting on the podium telling you what I do. That's not really evidence. Evidence is using what you can find in the literature. It's recognizing the limitations of randomized clinical trials. And I think it's very helpful to differentiate between what's belief and what's been shown in quality studies. I have a bias, and this is evidence-based, for oral antiviral therapy. And my reasoning is that it limits ocular surface toxicity. You don't have to worry about if the eye is red, whether it's being caused by the oral agent. These drugs, oral antivirals, are extremely safe long-term. We have 3 of them in the US that are interchangeable for the most part. There is this admonition not to use valacyclovir in patients with AIDS. That is a controversial admonition, and I follow it for medical legal reasons only. HSV lytic infection or epithelial infection is a systemic disease. It has to reactivate, and it reactivates in the CNS, and systemic agents get into the CNS. I also have the bias for not the strongest corticosteroid available, but what I call the strongest reasonable corticosteroid. For me, that's prednisolone when you need an anti-inflammatory therapy. And I like to avoid pseudo failures. If you give a weak corticosteroid and the patient doesn't improve, you still have that potential arm on your treatment algorithm should I have given a stronger corticosteroid. Prednisolone gets into the eye well. You can always change to a weaker drug. I personally avoid difluprednate in HSV keratitis because we so commonly see intraocular pressure rises. And as you know, those IOP rises can be caused by HSV. And I hate to use drugs that generate confusion rather than clarity. HSV stromal keratitis with ulceration may be an exception to needing a strong corticosteroid. I have many patients that after starting them on an antiviral, and I'll show you that in a moment, I give something like fluorometholone once a day, and their epithelial defect and inflammation clears within several days. It's quite dramatic. So obviously, any recommendations I would make are based upon medications available in your region, but I've tried to do these based on concepts rather than the specific drug. For epithelial keratitis, it's an antiviral, period. As if it's dendritic, you can use a therapeutic dose. When it's geographic, I worry about long-term neurotrophic keratopathy, and I will usually go right to the maximum therapeutic dosing. In the US, that might be valacyclovir, 1,000 milligrams 3 times a day. I also really like ganciclovir gel, which we have in the US. We're about to get acyclovir ointment finally, but the ganciclovir gel seems to be extremely well tolerated by patients with very minimal toxicity. Stromal keratitis without ulceration, the treatment is a therapeutic corticosteroid dosing, for example, prednisolone 6 or 8 times a day, along with a prophylactic antiviral. And for me, that's, for example, valacyclovir 500 milligrams once a day, or acyclovir 400 milligrams twice a day. As I've gotten older, I've become minimalist in my therapy. I like to give patients medications they don't need to take as often because I've learned that compliance improves as you reduce the frequency with which the patient needs to remember to take their medication. With ulceration, that gets flipped. So here I believe you need the therapeutic dosing of antiviral with what I call minimal touch dosing of corticosteroid. There's good evidence that in stromal keratitis with ulceration, there's very deep stromal viral replication. And through trial and error, I've arrived at this, which has, I think, been backed up by others' experience. In other words, a therapeutic antiviral that might be valacyclovir, a gram TID, and prednisolone once a day. I usually start the antiviral first, make sure they have it and they're taking it, and then I touch them with a little bit of corticosteroid. And it's remarkable how quickly these highly inflammatory lesions respond when you do this. They don't seem to respond to the antiviral alone fully. They might get a little better, but they don't heal. And then for endothelial keratitis, there are a couple of small clinical trials. In my own experience, both intentionally and by patient noncompliance, I've learned that you need therapeutic dosing of both the antiviral and the corticosteroid. And these patients can go from hand motion vision to 20/20 in 24 hours with a maximal dose of an oral antiviral and a 8 times a day dosing of prednisolone. At 2 weeks, I typically start tapering the corticosteroids. The antivirals can be reduced at 2 weeks to the prophylactic dose if you've started therapeutic dosing. What about prophylaxis? Well, the HEAD study, as I mentioned, never told us who to use it in. But these are eminence-based indications. I choose to offer prophylaxis patients who've had multiple recurrences of stromal keratitis. If they need to be on corticosteroids, I'd like to reduce that, so I give them prophylaxis. Patients with recurrent inflammation and scar and vessels that are approaching the visual axis, obviously our goal as corneal specialists is to preserve and restore vision in the, due to corneal disease. And so I try to catch it before they need surgery. More than one episode of stromal keratitis with ulceration is an indication for me because these are really the worst players and they almost universally lead to visual loss if not treated. And again, I'm very aggressive about using prophylaxis in patients who are having keratoplasty. And for me, very simply, I like the once-a-day dosing that I can do with valproic. I increase the dose if they break through, and I also use more in atopic patients because I believe that more is required, but that's eminence-based. There's no hard evidence for that in a clinical trial. So I just wanted to finish up with 2 cases that I thought you might like. This is a patient I showed before. He was a young man sent to me by a corneal specialist. The corneal specialist told me he had treated the patient with oral acyclovir, but the patient said that he had never taken a medication by mouth ever. I believe the corneal specialist was just covering his failure. He had a corneal transplant for herpetic eye disease, was having trouble wearing a contact lens consistently because of recurrent episodes of stromal keratitis with ulceration, and he was 2400. We placed him on oral acyclovir as prophylaxis, stripped the pannus, and here he is, went back to 20/40 vision with his contact lens and was happy. So it was fairly simple. This is one of my favorite cases. This was a dentist who had been on disability for 10 years. He presented to me and said, I don't want surgery. I want to know, can you do anything for me that doesn't involve surgery? I have burnt out herpetic eye disease. And you can see something, there's a finding here which we don't see very often, but it's a posterior collagenous layer like we're taught to see in syphilitic keratitis, where you get these sort of cracks in descimase, very characteristic. This is not corneal, these are not descimase folds. And you see this opacity at the posterior cornea. And it's a layering of extra basement membrane by a metaplastic corneal endothelium. And you can see the cornea is swollen. He's 2400. And because you can never tell at first visit whether a patient has active disease, really, I placed the patient on acyclovir 400 milligrams twice a day and prednisone 8 times a day as a drop and asked him to return in 2 weeks. Here he is 2 weeks later with 20/40 uncorrected vision, and he went back to work as a dentist. Now he had his depth perception back. So that's really all I have, and I thank you so much for your attention, and I'm happy to answer any questions that you might have.
Thank you very much,